the webinar series on seizures and epilepsy protocols. Basically, today we have two eminent speakers, Dr. Priya Agarwal and Dr. Praveen Kesav, who will be speaking regarding the management of post-stroke epilepsy. And to introduce the speaker, I'll request Dr. Ajay Asranna to introduce Dr. Priya Agarwal.
Thank you, sir. So first speaker today will be speaking on why and how of post-stroke epilepsy is Dr. Priya Agarwal. She is a consultant neurologist and epileptologist at SDMH, Jaipur. She has graduated from RNT Medical College in Udaipur and subsequently has done her DNB in neurology from RR Army Hospital in New Delhi. She's also done a postdoctoral fellowship in epilepsy she is working on epilepsy in Jaipur, and we a very warm welcome to you, madam, and we look forward to hearing more from you. If you could start with your presentation now, ma'am, you can start sharing your screen.
Thank you so much. Very good evening to all of you. A very good evening to all of you. Myself, Dr. Priya Agarwal from Jaipur. I would be speaking on post-stroke seizures, when, why, and how. Cerebrovascular illness is a very common cause of epilepsy after middle age. In the elderly, stroke accounts for more than half of all newly diagnosed cases of epilepsy. Over the last decade or so, there have been several researches in the management of stroke. However, the management of post-stroke seizures has not matched the research in other domains. Fortunately, there seems to be a growing research in this field too. As far as the epidemiology of post-stroke seizures is concerned, the reported long-term cumulative risk of the post-stroke seizures varies between 5 and 20%. In fact, it is a very wide spectrum, but this is just to say that the average of them, 5 to 20% for most of the studies. Similarly, the incidence of post-stroke epilepsy also varies widely. The variations reflect the differences in study cohorts regarding the stroke etiology, the study methodology, such as follow-up time, outcome measures, whether the patients remained in the study after developing subsequent strokes. The definitions of early, late, and unprovoked seizures have been quite different for different studies. Similarly, the timing of anti-epileptic drug administration also caused a lot of difference in the incidence of strokes. For some of the studies, the AED was administered prophylactically. In others, it was given after the development of first seizure, while in others it was not administered after one seizure. The sample size was small for most of the studies, and there were some ambiguities in the seizure identification. Last but not the least, some of the seizures might have remained undiagnosed. This is a summary of the selected studies on the incidence of post-stroke epilepsy that have been published in last 20 years. As we can see, this study has been conducted on all types of strokes. The patients included were those of acute ischemic stroke, were those of hemorrhage, while that of subarachnoid hemorrhage were also included in the study. The follow-up also varied widely. The outcome measures were post-stroke seizures, but as we have already talked about, these post-stroke seizures, epilepsy, early onset seizures, late onset seizures, they were not very much defined for most of the studies. And the cumulative risk of developing epilepsy following a stroke also varied widely. The average risk somewhere varied between 10%. The largest study to examine the post-stroke seizures was the prospective multi-center report done by the Seizures After Stroke Study Group. This was done by Bladin et al. The number of patients included for the study was 1897. The overall incidence of seizures was 8.9%, but the risk of epilepsy was only 2.5%, but the limiting factor was a very short mean follow-up of 9 months. Oxfordshire Community Stroke Project was a community-based stroke register. Stroke patients have about 11.5% risk of seizures in the first 5 years after a stroke. The classification of post-stroke seizures based on the timing of occurrence is conflicting and very debatable. The post-stroke seizures were initially classified as early and late onset seizures with an arbitrary cutoff point of 2 weeks in a paradigm that was comparable to post-traumatic epilepsy. The differences in the presumed pathophysiology of early and late onset seizures was also an additional factor that was taken into account while classifying these seizures. Most early onset seizures had a peak within first 24 hours and were subclassified as immediate seizures, while the late onset seizures had a peak within 6 to 12 months after the stroke ictus. As per the ILE, the practical clinical definition of epilepsy is the presence of even one seizure due to a stroke. This is because of the high risk of recurrence of the seizures after stroke, as was shown by various studies. However, this again is very controversial due to the conflicting data on the recurrence risk. ILAE also classifies post-stroke seizures into acute symptomatic seizures when the seizures manifest within 1 week of the onset of the stroke. Pathogenesis of early onset seizures following acute ischemic stroke. During acute ischemic injury, accumulation of intracellular calcium and sodium may result in depolarization of the membrane. These local ionic shifts may lower the seizure threshold. Glutamate excitotoxicity is a well-established mechanism of cell death that has been seen in the experimental stroke models. The ischemic penumbra is a region of viable neuronal tissue that lies very close to the infarcted core. It contains electrically irritable tissue, and this could be a focus of seizure activity as well. In addition to focal ischemia, global hypoperfusion can also cause seizure activity. Particularly vulnerable to ischemic insult is the hippocampus, which is especially very epileptogenic. Hemosiderin deposits are thought to cause irritability after a hemorrhagic stroke and thus produce seizures. In late onset seizures, persistent changes in neuronal excitability occur. Gliotic scarring has been implicated as the nidus for late onset seizures. An underlying permanent lesion appears to explain the higher frequency of epilepsy in patients with late than early onset seizures. What are the risk factors for post-stroke seizures? There are certain stroke subtypes that are more predisposed to develop seizures after the development of stroke. The concept that cardiogenic emboli to the brain are more likely to cause seizures is actually controversial. The patients who have had a probable cardioembolic stroke were not at elevated risk of a seizure, as seen in the SAS study the Lausanne Stroke Registry, and later the NINDS data bank study as well. Seizure incidence is higher in patients with ICH. As was seen in the SAS study, the risk of post-stroke seizures was 10.6% in patients with ICH versus 8.6 in patients with an ischemic stroke. TIA is very less associated with seizures, while CVT is commonly associated with seizures. Uh, Risk factors for post-stroke seizures as far as the stroke location is concerned. Cortical location is the best characterized risk factor for development of seizure after the acute ischemic stroke. And this fact is supported by several studies that may have widely differing designs. Total anterior circulation infarcts have a very high incidence of post-stroke seizures. Seizures may also develop in cases of subcortical and lacunar ischemic strokes. However, cortical involvement could not be totally ruled out in studies. Involvement of the hippocampus carries a very high risk of the development of post-stroke seizures. Analogous to cortical involvement in ischemic stroke, a lobar site is considered to be the most epileptogenic location in patients with intracerebral hemorrhage. Earlier studies reported an independent association of post-stroke seizures following a stroke. However, the later multivariate analysis that was done in subsequent studies found that after adjusting for stroke location and subtype, stroke severity was no longer associated with post-stroke seizures. In SAH, the presence of MCA aneurysms, intraparenchymal hematoma, presence of a cerebral infarction, and the thickness of the cisternal clot predicted the likelihood of post-stroke seizures. Reperfusion injury, mainly after carotid endarterectomy, is also associated with increased risk of stroke. Given that most post-stroke seizures are caused by a focal lesion, they are typically focal at onset. They may be tonic-clonic in 1/3 of them. Atypical presentations can always occur. A minority of the patients may present with non-convulsive seizures, hence may remain undetected. Um, in certain studies, status epilepticus was seen in around 9% of the cases. As far as EEG is concerned, the presence of plaids, bilateral independent plaids, and focal spikes were associated with a higher development of seizures, while focal slowing when seen carried a lesser risk of the development of seizures. Uh, TIA, particularly a limb shaking TIA, needs to be differentiated from a seizure. Similarly, syncope at times may be difficult to differentiate from a seizure. Todd's palsy may mimic a stroke recurrence. Uncommonly, seizures give rise to focal signal changes on MRI and need to be differentiated from acute ischemic strokes. Impact of post-stroke seizures on the outcome is uncertain. Uh, Even after the development of status epilepticus, the development of post-stroke epilepsy is not high, though mortality because of status epilepticus per se may be high. A word about pre-stroke seizures. Seizures may occasionally be a harbinger of stroke. Whether new onset seizures in the middle age warrant stroke workup is a question, since stroke is very common, is a common cause of epilepsy after middle age. This is very important to see. Current understanding of the pathophysiology, epidemiology, risk factors remains incomplete, and further studies are needed to exactly determine all these data. Thank you.
Yes, Ajith.
Dr. Priya has elucidated some of the things that we need to look as far as post-stroke seizures are concerned. Now I will request Dr. Praveen Kesav, who is a consultant in Cleveland Clinic, Abu Dhabi. He has done his MBBS from Trivandrum Medical College and MD from Alappuzha Medical College. And he has done his DM from PGI Chandigarh and a postdoctoral fellowship from Chitra in stroke. And he has got multiple uh, international papers to his credit. And over to you, Dr. Praveen, for how long to treat and how to treat post-stroke seizures.
Thank you very much, Ajith sir, and good evening from Abu Dhabi to the Elite group. And first of all, I would like to thank Professor Ashalatha madam for giving me an opportunity to present before this Elite group. So the topic which has been allotted to me is how to treat and how long to treat post-stroke seizures. Even though the questions are very simple, I tried my level best actually to find out the answers for the same. And then I realized that we don't have much of an evidence base with respect to the answering these questions. I'm sorry, actually, I'm experiencing a little bit.
It's visible, sir. Actually, you can go ahead, sir. I mean, is it hanging or?
No, it's hanging up. I'm not able to go to the next slide.
You can exit and do it again, sir.
Okay.
You can unshare and then share back, sir.
Yeah. Sorry for the
okay, sir.
Okay. So the overview of the topic is that, first of all, we will try to understand what is the relevance of discussing this topic. What is the evidence base regarding the primary anti-epileptic drug prophylaxis for early post-stroke seizures and late post-stroke seizures, evidence base regarding the secondary anti-epileptic drug prophylaxis, both in both these subgroups, what are the recommendations regarding the optimal anti-epileptic drug therapy, what are the evidence base for the duration of anti-epileptic drug therapy for post-stroke seizures as well as post-stroke epilepsy, and what are the future directions in which we can go ahead. So the relevance of discussing this topic has already been highlighted by my colleague, Dr. Priya Agarwal. Cerebrovascular disease is the most common cause of acquired epilepsy overall. It constitutes about 11% of the epilepsy population and about 45 to 55% of epilepsy in those beyond 60 years of age. And the rule of 1 in 6 holds good in stroke. As for post-stroke epilepsy, that means about 1 in 6 stroke patients can develop post-stroke seizures with a median duration of about 3.4 years from the stroke onset. And early post-stroke seizures happens in about 3 to 6% of ischemic population and 10 to 16% of the hemorrhagic stroke population, with a chance of about late post-stroke seizures to occur in about 6% of ischemic and 12% of hemorrhagic population over the next 5 to 10 year period. But the fallacy is the fact that despite being a very common cause for acquired epilepsy in adulthood, there is a lack of definite evidence-based guidelines for management of post-stroke epilepsy. But we are fortunate enough that at least over the past decade, there has been active interest going on in this field, as evidenced by the European Stroke Organization guidelines for the management of post-stroke epilepsy, which was published in 2017. And this guideline will be the basis for my presentation today. And as per the guidelines, we have defined acute symptomatic seizure or early post-stroke seizure as seizures happening within 7 days from onset of the stroke, as unprovoked seizure or the late seizure to be occurring beyond 7 days from the onset of the index event, and a primary anti-epileptic drug prophylaxis for initiation of anti-epileptic drugs to prevent occurrence of a seizure and secondary anti-epileptic drug prophylaxis for administration of medicines to prevent a recurrence of seizures once the initial seizure has happened. The first actually discussion topic is regarding what is the evidence base for primary anti-epileptic drug prophylaxis in strokes. So far, there is only one randomized controlled trial specifically addressing this issue, and this was carried out by the Israel group in 2011 in primary supratentorial intracerebral hemorrhage. In this study, out of a total of 72 people with intracerebral hemorrhages, they were randomized into two groups. One is the treatment group, which received valproate 500 milligram twice daily for a duration of 1 month, and the other was the placebo group who did not receive any anti-epileptic drug treatment. The duration of the treatment was for 1 month, and they were followed up for a duration of about 1 year. And what they found out was that the number of early seizures were slightly lesser in the treatment group when compared to the placebo group, but the number of the active number of events were less than 5, and therefore no meaningfully statistically significant conclusion can be derived out. One another point which can be identified is that the people who received the treatment with valproate had a slightly better NIHSS at 1 year follow-up when compared to the placebo group. And this was probably attributed to the neuroplasticity modulation effect of sodium valproate. However, this was a very underpowered trial and no conclusions could be derived out of this particular randomized controlled trial. And recently, Angryman et al. Had published a meta-analysis regarding the observational studies as well as randomized controlled trials for primary AD prophylaxis, and it was published in Stroke in 2019. And this study analyzed 3 observational cohort studies and 1 randomized controlled trial, which was mentioned above. The primary outcome considered was the functional outcomes and all-cause mortality, and the secondary outcome was the occurrence of the early and late post-stroke seizures. This study also concluded that there is no overall association between anti-epileptic drug usage and functional outcomes, or there is no relationship between the AED usage as well as primary prevention of seizure occurrences. So on the basis of this is the forest plot from the latest study which I highlighted, which indicated that the overall odds ratio for prevention of seizures with primary anti-epileptic drug prophylaxis was only 0.89. Hence, in the absence of adequate evidence base, the European Stroke Organization guidelines concluded that there is no evidence base for prescribing primary anti-epileptic drug prophylaxis either in ischemic or hemorrhagic stroke, both for prevention of early seizures as well as late seizures. This is also reinstated by the Cochrane database evidence, which was published in 2014, which also recommended that there is no adequate justification for anti-epileptic drug prophylaxis to be instituted for the purpose of primary prophylaxis in ischemic as well as hemorrhagic strokes. So coming to the secondary part, that is the secondary anti-epileptic drug prophylaxis to prevent either recurrent early seizures or late post-stroke seizures. So the early post-stroke seizures, majority of them happens within the first 24 hours of the index event. And the risk of recurrence within the first 7 days is very low, that is about 10 to 20%. But there are a few high-risk cases, as was highlighted by Dr. Priya in the previous talk, regarding the factors which can indicate higher chances for recurrence in ischemic stroke as well as hemorrhagic strokes. So in ischemic strokes, they tend to happen more in males, those who have hemorrhagic transformation, those having a cortical location of stroke, atrial fibrillation, having a severe stroke severity at baseline, presence of status epilepticus, and abnormal EEG as indicated by lateralized periodic discharges. Whereas the recurrence of early seizures in hemorrhagic stroke tends to occur more commonly in those having a cortical location of the bleed, age less than 65 years, those having a status epilepticus, hemorrhage volume of more than 10 ml, and those having abnormal EEGs. But despite these high-risk population groups, as per the European Stroke Organization guidelines, there is no evidence base to institute treatment for preventing recurrence of early seizures after an index early seizure within the first 7 days. But despite having said so, in clinical practice, we all tend to start the patient on anti-epileptic drugs within the first 7 days if the patient had an index event. That is mainly because of the fear of clinical deterioration and also to prevent further worsening of the neurological status or development of complications. But the clinical pearl, which I will be highlighting later, is that if in case we are initiating the anti-epileptic drug, it is always prudent to make sure that we taper the medicine after the acute phase is over. That means over a duration of 1 to 4 weeks. I will be highlighting about that regarding the same during the duration of anti-epileptic drug treatment. Now, the evidence is still more solid for secondary AD prophylaxis to prevent recurrence of late seizures or unprovoked seizures. The 10-year risk of unprovoked seizure after one early post-stroke seizure is about 30 to 35%. And the major evidence for this comes from the Rotterdam study, which was done in the late 2000s. And the 10-year recurrence risk of unprovoked seizures or late seizures after one post-stroke unprovoked seizure is about 71.5%. Now, as per the latest ILA guidelines, even after a single episode of a seizure, if the cumulative 10-year recurrence risk of a seizure is more than 60%, it can be considered to be an epilepsy. So in that case, a single unprovoked post-stroke late seizure is equivalent to post-stroke epilepsy. And hence the European Stroke Organization guideline states that due to high seizure recurrence risk, we can institute secondary anti-epileptic drug prophylaxis in these population groups. Now, again, there are a few high-risk populations which has to be given more importance, both in ischemic stroke and hemorrhagic stroke. And there has been certain scores which are being identified as predictors for recurrence of recurrent seizures. And for hemorrhagic stroke, one such score is called as the CAVE score, which indicates C for cortical involvement, A for age less than 65 years, V for volume more than 10 ml, and E for early seizure. Now we count each point, and the maximum point is 4 points. That indicates that there is a 5-year recurrence risk of about 46.2%, and these patients have got a higher risk for developing recurrent seizures. As depicted in this chart, the higher the number of CARE score, over the years, the chance of being remaining seizure-free comes down. Similarly, in the case of an ischemic stroke, there is a well-validated tool which is called as the SELECT score, which indicates which includes the severity of the stroke, large artery atherosclerosis subtype, early seizures, cortical involvement, and the territory of involvement of middle cerebral artery. And the maximum score that we get after calculating is 9 points, which indicates that there is a 63% chance of recurrent seizures at 1 year post-stroke and about 83% of recurrence at 5 years. So all these tools will help in identifying the high risk population who will require a longer duration of anti-epileptic drug treatment to prevent recurrent post-stroke seizures. Now once we have decided to give anti-epileptic medications for post-stroke seizures or post-stroke epilepsy, now comes the second most important question. What is the choice of the optimal anti-epileptic medication in this population? Now, from time immemorial, people have been managing post-stroke seizures with broad-spectrum anti-epileptic agents like phenytoin, phenobarbital, sodium valproate, carbamazepine, etc. But a few anti-epileptic drugs have got deleterious effects on the neurorehabilitation and the neuroplasticity, thereby ultimately affecting the overall recovery from the stroke as well. So it was towards the later part of 2000 that people started giving more importance to the newer anti-epileptic drugs so that they can be employed in the subgroup of post-stroke epilepsy as well. And a few studies that were actually starting the impetus for using the newer anti-epileptic drugs for post-stroke epilepsy was the SANAD study and the COMET study. Now we all know that SANAD was published in 2007 by Marson et al. And that compared actually the usefulness of lamotrigine, topiramate, and gabapentin against the broad-spectrum anti-epileptic drug of carbamazepine. And lamotrigine was considered to be actually the probability of remaining on this drug. That means the tolerability profile was much better when compared to carbamazepine, and it was identified to be non-inferior to carbamazepine for control of the seizures as well. Yet another study was the COMET study, which specifically looked into the tolerability profile of levetiracetam against the broad-spectrum anti-epileptic drugs like valproate and carbamazepine. Now, it indicated that, and this subgroup analysis was important to us in this particular aspect because it was done predominantly in the age group of more than 60 years, with more than 2/3 of the etiology being attributed to underlying cerebrovascular disease. So this study indicated that when levetiracetam was compared with valproate and carbamazepine, the treatment withdrawal rate at 6 months and 12 months was considerably lesser in the levetiracetam group when compared to the standard anti-epileptic drug group. And the seizure freedom rate was comparable as well. So these two studies paved way for utilization of the newer anti-epileptic drugs for management of post-stroke seizures. And now coming to the evidence base in management of post-stroke epilepsy per se. Now, during the early phase, as I already told, there is no evidence base for initiation of anti-epileptic medications. However, if we clinically find that there is an indication for starting the anti-epileptic medications to prevent the recurrence of early seizures, we have to always choose a medicine which can be rapidly up-titrated and de-escalated, because a longer duration of anti-epileptic medication is not at all justified in any clinical setting. And the ones which are commonly employed are levetiracetam, lacosamide, and the age-old ones, especially when the patient has got an underlying status epilepticus, sodium valproate and phenytoin. However, we have more solid evidence base for the anti-epileptic drug usage for late post-stroke seizures or post-stroke epilepsy. And there are two randomized control trials with regards to this. One was again from the Israel group done in 2007 that compared lamotrigine versus control release carbamazepine. And it was the inclusion criteria was primarily early or late post-stroke seizures after ischemic stroke. But here the criteria for inclusion was 2 weeks cutoff. And they had titrated lamotrigine and very gradually and compared it with carbamazepine over a duration of next 48 weeks. And the second group was an Italian group which compared levetiracetam versus carbamazepine. The inclusion criteria was primarily late stroke seizures, but they included both ischemic as well as hemorrhagic stroke. I will not go into the details of the study, but the final conclusion of these studies were in the first study comparing lamotrigine with carbamazepine, the seizure freedom was much better with lamotrigine when compared to carbamazepine, with the occurrence of adverse effects and withdrawal on account of adverse effects being much lesser in lamotrigine when compared to carbamazepine. And the second study by Consoli et al., the seizure freedom rate of levetiracetam was comparable with respect to carbamazepine, and the occurrence of adverse effects and the withdrawal was also comparable. However, then in a nutshell, this group of post-stroke epilepsy, we have to be very careful when we are selecting the anti-epileptic drug, because majority of them are elderly, they have comorbidities requiring intake of multiple medications, and therefore we have to choose an anti-epileptic drug which has got a safe pharmacokinetic profile, better ease of administration with minimal effects on cognition and lesser effects on motor recovery following stroke, and it should not be based just on the efficacy or the tolerability profile. Now, once the anti-epileptic drugs are prescribed, how are they being tolerated in this population? Now, the largest study till date is obtained from the Swedish stroke register study, which compared the prescription patterns of anti-epileptic medications in post-stroke epilepsy from 2005 to 2014, and also identified what was the tolerability profile of these drugs. Now, we can see clearly that when the study began in 2005, the major drug prescribed was carbamazepine, with the newer anti-epileptic drugs constituting only a small percentage. But as towards the end of the study period in 2014, the major drug which was prescribed was levetiracetam, and this is also identified by the fact that the tolerability profile is maximum for lamotrigine, followed by levetiracetam, and least for phenytoin. Now, this was the largest study which is available till date regarding the tolerability of the anti-epileptic drugs in this population. Now, what is how many patients do require a switch of the anti-epileptic medications once we initiate them on follow-up? Now, this was identified by this particular study, which indicated that roughly 60% of the anti-epileptic drugs which were prescribed in post-stroke epilepsy, patients tend to maintain on them well, and only 40% of individuals required a switch of anti-epileptic drugs, either due to inefficacy or due to tolerability issues. And among the 60% who retained their first anti-epileptic drug prescribed, the majority of them was constituted by levetiracetam. Whereas among the 40% group who required a change of the anti-epileptic medication, the majority was constituted by phenytoin, indicating that the newer anti-epileptic drugs had a better tolerability profile when compared to the broad spectrum older ones. Now, once we have chosen the drug, how can we decide how long the patient will require anti-epileptic drug therapy? Again, there are lack of clear guidelines pertaining to the duration of anti-epileptic drug therapy in this subclass. However, if I told you previously, we don't have an evidence base in acute symptomatic seizures or early post-stroke seizures. But if we are initiating, we have to make sure that it is only for the acute phase and it has to be tapered off over a duration of 1 to 4 weeks. For unprovoked seizures or post-stroke epilepsy, it is a very tricky situation. The minimal duration of seizure freedom, which is to be ensured before trying to taper off a medicine, is at least 2 years. But we should always think of these red flags before deciding on tapering of medications, because in this group of post-stroke epilepsy, we have a documented seizure etiology in majority of the cases. The EEG tends to be abnormal even at the time of discontinuation, either in the form of slowing with or without sharps. There, in patients who have got severe strokes, the neurological examination always tends to be abnormal at the time, even after recovery. There might be a requirement for 2 or more anti-epileptic drugs. Partial seizure types, 10 or more seizures prior to remission, longer duration of epilepsy, and a family history of epilepsy are all red flags which needs to be considered prior to deciding tapering of anti-epileptic medications. And it is a well-known fact that if there are 2 or more of the above mentioned red flags, it is prudent not to advise AED taper because of the high chances of recurrence of seizures. And because of these factors, majority of patients with unprovoked seizures or post-stroke seizures may need to continue the anti-epileptic drug for a long duration. However, the ultimate decision is to be taken after a comprehensive discussion with the patient by utilizing nomograms, which are available for general population as well. And if the AED AED stop is planned, go for a slow taper and a regular follow-up to be ensured at least for 2 years post-taper to look for whether there is any high chance for recurrence or not. Now, this is one of the normograms which are available for general population to help in predicting what is the recurrence risk at 2 years and 5 years, so that an informed decision can be taken after discussing with the patient. Now, coming to the last part of my discussion, what are the future directions in which we can proceed with respect to the devising guidelines for management of post-stroke epilepsy? Now, identification of a potential biomarker which can predict development of a post-stroke epilepsy can help us a lot in identifying those people who tend to have a higher chance of developing post-stroke epilepsy. Thereby, we can titrate the anti-epileptic medications accordingly. Now, we don't have evidence base as to what is the role of EEG, including the 48 to 72 hour continuous EEG monitoring in the early phase of stroke in prediction of post-stroke seizures or post-stroke epilepsy. And relationship between revascularization strategy in ischemic stroke and post-stroke epilepsy risk should also be identified as to whether people who are undergoing the IV thrombolysis or mechanical thrombectomy have got a higher chances for developing post-stroke epilepsy in the later date or not. However, the need of the hour is a long-term, prospective, multicentric, high-quality studies with large cohort of patients, preferably involving stroke registries. And we have actually upcoming randomized controlled trials in this regards, and one of them is coming up from the All India Institute of Medical Sciences, where they are randomizing patients with ischemic as well as hemorrhagic strokes for prophylactic levetiracetam therapy to prevent post-stroke seizures, which is called as PRO-LEVIS. They have started recruiting patients from 2018, and it is an ongoing trial. And I think it is sufficiently powered, and this is one of the biggest trials which can help us in providing further evidence-based guideline modifications for the AED prophylaxis. This is the summary, but I would rather actually not discuss much about this because my colleague Dr. Paresh will be discussing about the guidelines, a summary of the guidelines for management of the post-stroke epilepsy. And this is in fact what I could gather actually out of the current evidence base for how to treat and how long to treat post-stroke epilepsy. Thank you very much.
Thank you, Dr. Praveen. It has been a wonderful discussion that you have done based on the current available data. As you have rightly pointed out, in the early seizures, early onset post-stroke seizures, As you have rightfully summarized, it is judicious to taper and stop the medication maybe within 3 or 4 weeks. And after which, when you have a late onset event, the cumulative risk is more than 60% over a 10-year period. So this is one of the conditions. Other than trauma-induced seizures, late trauma-induced seizures, as well as late post-hoc seizures and late post-encephalitic seizures. So these are the other conditions other than nocturnal seizure, where even a single episode of seizure is warranting you to start anti-epileptic drug. And as you have rightly pointed out, stroke is a disease of the elderly. And the elderly, we have seen that lamotrigine is an extremely good drug as far as the tolerance and the compliance factor is concerned, especially the OD preparations which are available. And they are actually tolerating lamotrigine much better than the other sodium channel blockers, especially oscarbazepine or even phenytoin. And as you have pointed out, lamotrigine is the best tolerated among all the medications that are currently given for post-stroke epilepsy. I think you have put out the gist very, very clearly, lucidly, and thank you very much. Now to introduce our moderator, I will request Dr. Ajay.
Thank you, sir. So after 2 excellent sessions, now we have the third session. This will be, the speaker will be Dr. Paresh Zanzmera. It is a pleasure to introduce Dr. Paresh. He is a neurologist and epileptologist based in Surat. He has done his DM neurology from All India Institute of Medical Sciences and done a postdoctoral fellowship in epilepsy from Sri Chitra. He will be speaking on what reasonable protocols can be developed for treating post-stroke seizures. Welcome, sir, and we are waiting to hear from you as well.
Yeah. So thank you very much, Dr. Ajay, for introducing me. And at the outset, I would like to thank Professor Dr. Ashalatha, Madam, who gave this opportunity to present my viewpoint on how, like my 2 colleagues, Dr. Priya as well as Dr. Praveen, has done wonderful job, and they have done my job brilliantly, right? So I'll be just touching a few of the points, and we'll find out few of the answers of some of the questions which can be like help us to decide in certain situation what we can do to by the existing evidence and some practical approaches. Like, so I'll just briefly touch on this definition classification once again: epidemiology, pathophysiology of the post-stroke seizure, as well as early post-stroke epilepsy, and what are the predictors for development of the seizures, and some of the guidelines and recommendations, right? So we already discussed, so I'll not go much in the details, but there has been some early post-stroke seizure can be varied depending on the various authors who have involved their patients in particular studies. So particularly up to 7 days, it is termed as early post-stroke seizure, but maximum seizures would occur in first 24 hours. Late post-stroke seizures would appear between after 7 days up to 2nd year of the acute stroke, especially after, but the peak would be between 6 months to 1 year. And so there is some thin line between the what is post-stroke seizure and post-stroke epilepsy, right? So the post-stroke seizure are the one which occurs within the acute phase of the stroke, right? So that should not be confused with the post-stroke epilepsy, which do not have any provoking factor because of the acute stroke involvement. And the single or multiple convulsive episode after stroke and thought to be related to reversible or irreversible cerebral damage because of the stroke, regardless of the time of onset of the stroke. While post-stroke epilepsy is basically unprovoked seizure, which is not provoked by any factor like metabolic or toxic or any other factor, or there is increased probability like 60% of recurrence and subsequently require anti-epileptic medication to achieve seizure control, right? So these are the recurrent seizure of following stroke with confirmed diagnosis of the epilepsy would be termed as post-stroke seizures. My colleague Dr. Priya has already mentioned that there are certain risk factors of there are some like incidence and prevalences of the development of the early as well as late seizures in adult population as well as in pediatric population. So I'll just tell this particular chart has also been discussed by Dr. Priya. So I'll just tell that the role of, the stroke as an etiology for development of the epilepsy, that is termed as post-stroke epilepsy, is around 5 to 10%, roughly 11% of the all cases of the epilepsy, while relative risk of the seizure occurring within first 24 hours of the stroke was much higher in pediatric population as compared to adult. That was 18% time. So pediatric epilepsy, if they occur within first 24 hours of the stroke, actually seizures, then they have very high chances of development of late seizure or post-stroke epilepsy. If the patient's age is more than 60 years, then almost half of the patient seizures, occur within the first time of their life as a consequence of the ischemic stroke, right? So elderly population also very high chances of development of post-stroke epilepsy. Again, Dr. Praveen has already mentioned this early post-stroke seizure or acute symptomatic seizures. They are more common in hemorrhagic severe stroke, 10 to 60% as compared to ischemic severe stroke, which is around 3 to 6%. And late post-stroke seizure or unprovoked seizures, they are again very common in hemorrhagic severe stroke as compared to ischemic severe stroke over 5 to 10 year follow-up. So what are the pathophysiology of the early as well as late symptomatic seizure? This has been touched by Dr. Priya, but I will just tell that early in the development of the stroke, there will be liquefactive necrosis. And because of that, there will be cellular swelling, and there will be like breach in the membrane, which will allow the calcium as well as sodium to accumulate intracellularly, and that will reduce the threshold of the depolarization, and there will be also involvement of glutamate excitotoxicity, which will lead to development of the early seizures. And this is all because of the hypoxia, and that will reduce the generation of ATP from the mitochondria because of the damage of that, and that will lead to metabolic dysfunction, especially this also because of the IV thrombolysis or in carotid aneurysm, there will be reperfusion injury, which will lead to development of radicular injury. That will be like oxygen radicals that will be involved, and that they will lead to development of the early seizures. While late onset seizure, they have completely different etiopathogenesis. Like after 5 to 10 days of acute stroke, there will be migration of the astrocytes towards the site of the injury, and that will start developing gliotic scars, which will be a long-term process, like almost months to years following the stroke, and that becomes the main epileptogenic foci for the development of the late symptomatic seizures. Again, in case of hemorrhagic, this is particularly in the ischemic stroke. In a hemorrhagic stroke, there will be irritation of the central nervous system, cellular level, because of the blood accumulation, as well as deposition of the hemosiderin later on can lead to irritability of the surrounding CNS, and that becomes the foci for development of the epilepsy later on, as far as hemorrhagic severe stroke is concerned. So, can we predict the development of the stroke? What are the various risk factors for development of the stroke? So as far as severe stroke is ischemic severe stroke is concerned, the larger stroke or cortical involvement, severe initial neurological deficit, or persistent disability, severe persistent involvement of the multiple site, especially hippocampal involvement or embolic stroke, they are more commonly associated with later development of either late seizures or post-stroke epilepsy. Although there are less evidence of ischemic intracranial hemorrhage to develop post-stroke epilepsy, but we all know younger age than large volume of the ischemic stroke, cortical involvement, they are the risk factors. As far as subarachnoid hemorrhage is concerned, middle cerebral artery aneurysm, intraparenchymal hematoma, or EEG abnormality or focal seizure at the beginning would become the risk factor for development of late symptomatic seizure or post-stroke epilepsy. Then Dr. Praveen has already touched this. There are some scores which will help us to predict development of post-stroke epilepsy. Like one of them is published in 2007 Journal of Neurology, and these are the 7 item stroke scale, which will help us to help us to identify which are the patients who are more prone to develop post-stroke epilepsy, which has very good highly sensitivity as well as specificity and predictive values like as high as 87.5%. As far as intracranial hemorrhage is concerned, Dr. Praveen has already mentioned this cage score, and if it satisfies all 4 points, then 5-year accumulative risk of development of post-stroke seizure is 46% as compared to only less than 1% if there is no any such kind of involvement. Again, this is another scale for select scale for the post-stroke epilepsy following ischemic stroke, which will involve the severity of the score depending on the NIHS, then subtype of the ischemic stroke, that is large artery thrombolysis, atherosclerosis, early seizure, cortical development, and territory of the MCA involvement, yes or no. And these are maximum 9 points. And if we see that Dr. Praveen has nicely mentioned that if we have all the points like 9 points, then at the end of the 1 year following severe stroke, there will be 63% chance of development of the stroke as compared to, I mean, at the end of the 5 year, it will raise to almost 80% of the patient will develop severe stroke. So again, what are the clinical presentation which are commonly seen in a patient with severe stroke? That is 2/3 of the patient, they have focal onset seizure, especially in early symptomatic seizure. Like 1/3 of the patient, especially in the late post-stroke seizure, they have generalized epilepsy. But obviously, if we go in the detail, it will be kind of secondary generalized epilepsy. 9% of the patient with the stroke, they have a status epilepticus as a presentation of their seizures. They do have poor immediate prognosis, but however, that does not predict the subsequent development of late post-stroke seizure or post-stroke epilepsy. Another thing is that the type of the stroke as well as topographic finding, size of the lesion, EEG pattern, they do not predict the progression to status epilepticus. So, like coming to the investigation, does EEG help to guide us? Like if the EEG shows, as Dr. Priya has also already mentioned, if there is a focal spikes or plates or biplates, then there are high chance of development of the post stroke epilepsy, but only a focal or diffuse slowing, then there are very less chances of development of post stroke epilepsy. However, in a certain studies, like especially done from the SGPGI India, in a prospective study, they found out that at the end of 16 months, there was no specific EEG pattern was found to those who later develop epilepsy, right? So initial EEG did not help actually in deciding whether they had a seizure or not. In fact, EEG could be normal in 5% of the cases, and therefore normal EEG does not rule out epileptogenicity or later development of epileptic seizure. Now coming to the management part, like I will have a certain questions and let us see the evidence or practical guidelines can give us any of the answer, right? So Dr. Praveen has already touched this, so I will be very brief into it. Does immediate primary prophylaxis with anti-epileptic medication prevent the occurrence of acute symptomatic seizure? Only one randomized control trial is there, and again the quality of evidence is very low. There was severe inconsistency as well as poor precision, right? So this whatever the current evidence is that the observational studies as well as one randomized control trial, the risk of development of ASS is very less than 5%, right? So quality of evidence is again very low and weak against starting any anti-epileptic medication prophylaxis for prevention of acute symptomatic seizures. Likewise, is there any anti-epileptic medication can be started to prevent unprovoked seizure in a patient who has just presented with the seizure, right? So again, there are no randomized control trials. Some observational studies are there, and they have shown the significant risk factor for development of the seizures, like ischemic stroke, if there is a cortical involvement, or acute symptomatic seizure, severe stroke, or MCA territory infarction, they can have like development of seizure almost 10 to 12% versus, or even 44% if they had a MCA territory infarct with craniotomy. If there was a cortical involvement of younger age, more than 10 ml or blood volume, or acute symptomatic seizure in hemorrhagic stroke, again development of seizure is like 46%. In a patient with suberectron hemorrhage, if the volume was more than 15 centimeter cube, then 1/3 of the patient would develop seizures. However, the quality of evidence at present is very low, and that's why to initiate anti-epileptic medication to prevent unprovoked seizure, we should not, and there is no recommendation to start any anti-epileptic medication prophylaxis. These are the patients who have not had any single seizure, and that's why we are there is no evidence, or we should not start any anti-epileptic medication, although they have very high risk factor of development of seizures. Now, like coming to, if the patient has one seizure, does immediate secondary prophylaxis compared to no anti-epileptic medication prevent occurrence of further acute symptomatic seizure? This is acute symptomatic seizure, not late onset development of post-stroke epilepsy, right? So this has to be like bear in the mind that for the risk of recurrence of acute symptomatic seizure is very low, 10 to 20% in observational study. There are obviously no randomized control trial. Again, the quality of evidence is very low. The strength of recommendation is very weak, and the recommendation is not generally employing secondary anti-epileptic prophylaxis, despite the fact that the patient had one seizure, right? But these are the patients who do not need to continue on any anti-epileptic medication later on. Now coming to the another group of the patient who had at least one seizure and unprovoked seizure. So this particular subset of the patient, they had one symptomatic seizure, like this of the patient who have unprovoked seizure following stroke. Does immediate secondary prophylaxis will prevent occurrence of further unprovoked seizure? Again, no randomized control trial, but Dr. Praveen has already mentioned that there are high risk of recurrence, almost 70% in unprovoked seizure over 10 years as when they had one post-stroke seizure. There are some controversial studies also exist which indicates immediate anti-epileptic medication after first unprovoked seizure does not improve the remission rate. Again, the quality of the evidence is very low, but we can recommend weekly for employing anti-epileptic medication, that is for secondary prophylaxis after one above unprovoked seizure that need to be considered. Like, so who are those patients who will require anti-epileptic medication? Again, at least one or ideally nearly two unprovoked seizure which following stroke, or post-stroke seizure with status epilepticus, which also include non-convulsive status epilepticus, or stroke with abnormal EEG, which includes plates and biplates. So for post-stroke epilepsy, the decision to initiate anti-epileptic medication should be individualized once again, primarily based on characteristic of the seizure episode and patient preference. Like most of the patients, they are geriatric one, and they have a lot of like ongoing medications, as well as there will be a different pharmacokinetic as well as pharmacodynamic properties, right? So the choice of the anti-epileptic medication should be individualized depending on the quality of the life of the patient. Now, what are the evidences which is available for selecting anti-epileptic medication? So again, two randomized control trial which has compared the efficacy of two different anti-epileptic medication. Both are underpowered. Outcome of these trials were seizure freedom rates did not differ at the end of 1 year. Comparison between levetiracetam and carbamazepine in one, and comparing lamotrigine and carbamazepine in other randomized control trial. Right. So, but the ILE, depending on the various observational studies, they have found out that initial monotherapy in adult with focal seizure, there are level A evidence for carbamazepine, levetiracetam, phenytoin, and zanisamide. Especially for the elderly patient, the recent guidelines, the recent trials of newer anti-epileptic medication, especially the lamotrigine as well as gabapentin, carries level A evidence. So now we'll have to depend on SANAD and COMET trials. We can depend on the subgroup analysis or extrapolation of these studies, like Dr. Praveen has already mentioned. As far as SANAD trial is concerned, the efficacy and tolerability were compared among gabapentin, lamotrigine, oxcarbazepine, and topiramate. Gabapentin, although found to be less effective, and lamotrigine was better tolerated than the other drugs. In COMET trial, levetiracetam was compared with valproic acid and carbamazepine as initial monotherapy, especially in the elderly population, right? So this is more reliable evidence. The levetiracetam had obviously better tolerability as well as less severe treatment withdrawal effect than other anti-epileptic medication. However, there was no difference between the drug efficacy. Like Dr. Praveen has already mentioned that it was non-inferior as far as this levetiracetam is concerned versus carbamazepine. Right. So the conclusion could be like newer anti-epileptic medication like levetiracetam and lamotrigine have better tolerability than the older anti-epileptic medication like carbamazepine and phenytoin, and that should be the given preferences as far as choosing the anti-epileptic medication is concerned for post-stroke seizure as well as post-stroke epilepsy. Now, another question, does immediate but temporary anti-epileptic medication prevent later occurrence of unprovoked seizure? Like these are the patients who did not have any unprovoked seizure, and should we start anti-epileptic medication? There were two randomized control trial. They compared 4-week treatment with valproic acid versus placebo in one of the trial, and another aim to compare levetiracetam versus placebo for 12 weeks. In first trial, which was carried by Glad R et al., which was published in Research, Epilepsy Research, there was no significant difference in the seizure outcome at the end of 1 year between the two groups. And another randomized control trial, which was published in Seizure 2011, was stopped actually prematurely because there was poor recruitment. Only 16% could be recruited, right? So both of these randomized control trial, they were found to be underpowered, and the quality of evidence is downgraded to very low because of severe biases as well as inconsistencies and imprecision. So, but again, this one observational study in which they have found out that the statin, apart from the role of lipid lowering agent in acute ischemic stroke, it was like independent predictor of less likelihood of development of later unprovoked seizure, right? So this particular thing, the statin, beyond its effect of lipid lowering effect, we already know that it had anti-inflammatory properties as well as a lot of other properties, but this is something new that it probably also has anti-epileptic medication. Don't know the detail about why and how, but this was like one of the independent predictor and one of the studies. If the patient had multiple early seizures within 24 hours occur, or an early seizure occur after intracranial hemorrhage or hemorrhagic transformation, studies suggest that short-term treatment may be beneficial for preventing a late onset seizure or post-stroke epilepsy, but the evidence is not strong enough to make a general recommendation. So overall, there is a general recommendation that not generally employing anti-epileptic prophylaxis in such patient of the age group. So I'm not going to go in the detail of this functional outcome of the stroke following anti-epileptic medication, but there were 3 anti-epileptic randomized control trial. I'll just go by the conclusion of the things. The quality of evidence is low, and then therefore the strength of recommendation is weak against not to employ temporary anti-epileptic medication to prevent later occurrence of epileptic seizure or improving the quality of the life, right? So anti-epileptic medication does not improve the functional outcome or quality of the life in such population. And is there any effect of anti-epileptic medication on mortality of the patient following stroke? To randomized control trial, again, the underpowered studies, and the recommendation is like weak against employing any anti-epileptic prophylaxis to prevent any mortality or death. So I'll just be in the end of my discussion. Dr. Praveen has already mentioned what are the future directions. High level of evidences are not actually there until now. So more and more randomized control trials are needed, or conducted prospective cohort studies are needed to answer a lot of questions as far as post-stroke epilepsy is concerned, or late development of late seizures in a patient with epilepsy. And there is hunt for development of newer biomarkers for the identification of epileptogenesis, and therefore a selection of at-risk patient for development of future preventive treatment. This could be in the form of blood test, or for brain injury or inflammation, or could be MRI, fMRI, HFO on EEG or TMS or MEG, or combination of any of the things which can help us to detect something which will give us some idea whether such population of the patient will develop later on seizure or not. And this is the last slide which Dr. Praveen specifically asked me to speak. Thank you, Dr. Praveen, for that. And let us try to find out these particulars are if the patient had post-stroke seizure, just find out whether he had presented with status epilepticus or not. And if the patient had status epilepticus, actually risk are seizure recurrence is very high, probably higher than the single seizure, and we should offer anti-epileptic medication at that point of the time. And if later on, if this patient had a recurrent seizure, then probably the diagnosis of post-stroke epilepsy can be easily made. If the patient initially did not have any seizure, and the timing of the onset of seizure should be noted for. If it is early, less than 7 days following stroke, and if it is intracranial hemorrhage, then there are high chances of development of recurrence as compared to ischemic stroke. Again, like post-stroke epilepsy is like comparable 5 to 30%. So if the patient is having recurrent seizure, and if there is status epilepticus, if there is no, then we can consider as a recurrent seizure, and we can start with anti-epileptic medication considering the diagnosis of post-stroke epilepsy. And if the patient had later development of the stroke, then we have to see for overall 70% risk of development of post-stroke epilepsy, right? So in this patient, we have to look for the individual risk factor that will help us to diagnose post-stroke epilepsy, and these are the subset of the patient which will require anti-epileptic medication. I think just this will be my last slide. The seizure and epilepsy after stroke is very common. Late onset seizure has higher recurrence rate as compared to early onset seizure after a stroke. The management of post-stroke seizure is a challenge because of there is no evidence, evidence-based data is available, and there are no reliable guidelines. Current data suggests that epileptic early seizures occurring after stroke are not warranted any anti-epileptic medication because of a lower seizure recurrence rate, and levetiracetam as well as lamotrigine are the best tolerated anti-epileptic medication in a patient with post-stroke epilepsy treatment. Thank you very much.
Thank you, Dr. Paresh, for that excellent summary. Can you keep that algorithm slide there? Can you keep that algorithm slide? Summary chart. Can you put it in that slide presenter mode? This is a very good slide, actually, what you have pointed out. Because in the early post-stroke seizure, one of the most important things that is haunting us regarding is that, is there a real advantage of starting or continuing or maintaining a anti-epileptic medication for a protracted period? Because neuronal plasticity is very important for post-stroke rehabilitation. Now, dendritic arborization and new dendritic synapse formation will be hampered by this anti-epileptic therapy. So, if you have got a stroke, we want other normal brain areas to take up this function. So, that means neuronal plasticity has to develop, means that new dendritic synapse has to form, and the residual brain area has to take a function. So, that is why one of the key reasons why, where there is no real need for protracted anti-epileptic therapy, it is better not to continue. So that is the rationale for suggesting that in the early post-stroke seizures, the long-term risk is actually on the lower side, and there is no real need. But the story is different when it comes to a late post-stroke seizure, that is even which is happening after 7 days. So even a single event means that your risk is actually more than 60%, and even with a single episode, actually you can start anti-epileptic therapy. So I think all three of you have brought these aspects very beautifully out, and especially you have pointed out that there's a Green Journal article which has showed that even statin has some role in managing things. So it's maybe more of a suggestion. Now, I don't know whether Himanshu is here or not, and or he has already left. He had suggested that there is something regarding the pharmacogenetic marker for lamotrigine, which helps him in loading lamotrigine. If Himanshu is there, can you just explain that aspect? I think
Yes,
he would have all.
he's putting a lot of comments, Ajith, and last time he was telling me he is very much interested in this particular topic than the topic I gave him. So Praveen must be knowing they're working together, I suppose. So where is he? Is he here?
I think in between I saw Himanshu left actually. That's why I just asked whether he's still there.
Okay, fine,
Okay.
fine. Then no
Okay.
problem.
Then another
Carry on.
question which was asked was, how about the watershed strokes? Is there a real increased risk with watershed strokes, basically, compared to the other strokes? Can any of the speakers or the moderator answer this question? How about watershed strokes?
Can I?
Yes,
Yep.
Praveen?
Yes.
So, yep. Classically, the watershed strokes tends to occur more commonly in cardioembolic strokes. So that was, and also the cortical location of the stroke is also a risk factor for developing these post-stroke seizures. So the initial observational studies, watershed infarcts were found to be associated with earlier and more number of post-stroke seizures as well as post-stroke epilepsies. But in the larger studies, it has not been found to be a significant risk factor. So that is why actually it has gradually gone out of the context.
Oh, okay. Thank you, Praveen. I think I have also, maybe people would have noticed that watershed strokes, actually there is a slightly increased risk for seizures. That is something which we have clinically observed. But as you have pointed out, if there are no studies which are supporting that, it may not be worth it. Any other questions? Tell me.
Just one additional point, sir.
Yes.
Actually, when in almost all the reviews actually for management of post-stroke seizures and also regarding post-stroke epilepsies, univariate studies, one of the variables was actually a watershed infarct, predominantly in the early studies, especially the ones which actually Dr. Priya mentioned, which was done in the earlier part of 2000s, like the seizures after acute stroke or the SARS study. But later on, actually, it was found out, then it was thought that cardioembolic strokes are more likely to produce recurrent seizures because of the higher chances for hemorrhagic transformation in them. But again, it went into disrepute, particularly in larger studies. And now, if you recollect the SELECT score, the L actually stands for the large artery atherosclerosis. So the studies have now proven that it is a more potent risk factor for developing post-stroke seizures rather than the age-old concept of cardioembolic strokes. But actually, in clinical practice, I think we do tend to see more of cardioembolic strokes which are having hemorrhagic transformation, having a higher chance for developing recurrent seizures. And the second largest group are the large artery strokes due to the underlying atherosclerotic changes.
One another feature may be because the cardioembolic strokes especially can occur in the posterior circulation, and the pituitary, which is supplying the hippocampus amygdala region, may be more vulnerable. That could be one reason why you can have a cardioembolic having more incidence of post-stroke epilepsy.
Yes,
and
sir.
also it can have a like more of cortical involvement as well as multiple sites of involvement as
Yes,
compared to other
correct.
right? So more chances of development of seizures.
So I was going through the chat box. It was all compliments basically. So one question has now come. This is from Dr. Shivamumar. Valproate increases mortality in stroke and increases MI. Can anyone comment on this? There's a publication in December 2019. Dr. Shiva, do you want to comment on that if you have read this article? Dr. Shiva, are you there?
But general like
okay, fine. He can.
guidelines.
Okay.
AHA guidelines, like when there was no early seizures and they have gone against prescribing any anti-epileptic medication in such age group of the patient, is like one of the fact is that they actually deteriorate the functional outcome of the patient in the early phase, right? So rather than improving, they have a deleterious effect on the CNS examination also, like prescribing any prophylactic anti-epileptic medication. This is one of the evidence in against of prescribing anti-epileptic medication. I'm not like telling valproic acid in particular.
This is as I said about regarding it has an adverse effect on the neuronal plasticity, arborization, and the new function being taken up by the cortical neurons which are left back. Okay. Are there any other questions?
So one question Dr. Hasib has asked about slow titration with lamotrigine being the challenge. And he's asking for comments from the speaker and the chair regarding that.
Correct. That's why I saw that actually. That's why I asked Himanshu, because Himanshu was saying regarding a rapid titration after some marker, identifying some pharmacogenetic marker. So I am not aware of that stuff. Are you aware, Ajay? Because he has written that rapidly escalating or giving load. Even he has written regarding loading doses of lamotrigine being given after identifying this marker. I think there could be some paper on that. I don't know. Any of the speakers or moderators would like to comment on that? No.
This is again actually the drawback, as we all know, actually, for lamotrigine. That's why I specifically highlighted that levetiracetam is much better in that aspect. And one of the newer drugs like lacosamide is also commonly used in this subclassification. But again, we don't have much evidence base with respect to this. But I am personally unaware of the rapid titrating doses of lamotrigine. And it's also depending on, we want the effects to be developing as early as possible. So in this phase of a acute stroke, developing a seizure, I think the titration of lamotrigine will definitely take a longer time when compared to the other medications. But I'm personally unaware of the rapid titration protocol of the same.
Okay.
Yeah, good evening, Dr. Hassan here.
Oh, okay. Tell me.
Yeah, actually, the same thing, despite having evidence for lamotrigine, especially we understand that for early patients, levetiracetam is something which patient practically is started on because emergency is protocol and we have IV medication. But even like the patient were not able to tolerate levetiracetam, nowadays people are becoming more and more comfortable with lacosamide despite not having that evidence, and lamotrigine despite having evidence, just because it has slow titration and the risk of Stevens-Johnson syndrome. We somehow avoid to use it despite having medicine. That is one of the paradox which I personally come across when I start trying to switch these patients from levetiracetam, either because of intolerance of lack of, or maybe the breakthrough seizure. So usually, somehow opt to for lacosamide rather than lamotrigine, just because of these two clinical barrier which we have. One is Stevens-Johnson syndrome, and other is basically a very slow titration.
Okay.
So I think Ajith.
Okay.
Ajith and Ajay, yeah. So
Yeah.
since we did not have one session, I think last week or maybe the second Saturday, that's going to be the next Saturday. So we have back-to-back 2 sessions, and one is on life beyond neurology. This time it's a very interesting topic for all of us because it's related to the financial aspects of life. After all, we all live and work and for our daily bread. That's what most of the people say. So that is going to be done by Dr. Gopal. So next week we are just shifting our gears to the video part of the epileptology, and I hope that there will not be any technical glitches. That is what is commonly seen. So I request both the speakers who are here today to have a dry run just 1 or 2 days prior to the program. And thanks a lot, Dr. Priya, Praveen, and Paresh have done a wonderful job, as well as Ajith and Ajay also. Thank you all.
Thank you, madam.
Thank you,
Thank you
one
so
and
much.
all. Thank you, madam.
Thank you.
Thank you.
Thanks.
Dr. Praveen.